as survivors of brain injury, we all have unique clusters of symptoms, right? We have, some of us have difficulties with migraine, some of them have emotion dysregulation, short-term memory, long-term memory. Some of us have difficulties with balance or vision. And so today we are very, very blessed to have Dr. Almouradi to talk about how neurooptometry can be helpful for concussion and the communication between your eyes and the brain after head injury. And so please join me in giving a warm brain injury welcome, Dr. Almouradi.
Thank you. Hi, everyone. Thank you for having me in your night class today. So as Daniel mentioned, I'm going to be speaking about how not just concussion, but traumatic brain injury and acquired brain injury in general has to do with vision and how visual symptoms make sense in different deficits of TBI or ABI. And what you can do about it, basically. So a lot of these symptoms, when I joined, I heard a little bit earlier, a lot of TBI patients have that feeling where, no, I'm fine. If I can just push myself harder, then it won't be blurry. If I can maybe squint and look, it won't be double. So, and there's not enough, I guess it's been overlooked because there's so many other therapies and so many things that take priority usually physically, that vision gets overlooked often. And so that's what we're going to be talking about today. Thank you. So basically, you're seeing through your brain, not through your eyes. Your eyes just bring in the light. Your brain processes all that information. And if there is any deficits in any part of it, then you're going to have all these symptoms. So my name is Dr. Yamam Almouradi. I work in 2 different offices, one in Norwalk and one in Brea. The closest one to St. Jude is Brea. We're about 10 minutes away. And so I'm in charge of the neurological visual rehabilitation and vision therapy clinic in that office. And if you can hit next. And so the email right there, you can send me any questions afterwards if you'd have, it's going to be a lot of different information. So as you think about it, think about your symptoms. If you have any questions, go ahead and send me an email and let's get started. This is also not a lecture, so I'm not talking at you. If you think of any questions throughout, feel free to stop me so we can have a chat about it. Feel free to stop me anytime. So basically, neurological visual rehab is known as vision therapy. It is a customized treatment program prescribed to alleviate conditions like lazy eye turns, intermittent blur or eye focusing issues, convergence and divergence issues, so anything where the eyes aren't working together as a team, and as well as other things like motor coordination, hand-eye coordination, information processing deficiencies, and other learning-related visual problems. And so this is actually beneficial for both children and adults. Old school textbooks would say there is a specific age where up to 13 years old, someone would be in what's called a critical window to fix all issues. But new studies found out that no, with concussion, with traumatic brain injury, the brain is very plastic. And so we can always reteach these skills. So with visual efficiency, there are 2 different things that we will be talking about. They're kind of 2 different pathways in the brain and eye-brain relay center. One is visual efficiency, which is how the eyes work together in crossing, uncrossing your eyes, in eye focusing, eye tracking. And the other one is information processing, which we will talk about a little bit later. Both can be affected as a result of TBI or ABI. So the first one here with convergence insufficiency, this is how we use both eyes together in order to cross to a certain point when we're reading or doing anything up close. So ideally, our eyes would be straight ahead when we look far away, but then when we are looking at something up close, depending on where that distance is, we have to cross our eyes, and both of them have to cross equally and come to a specific point in order for us to see things clear and single. We also have to have enough stamina to keep those eyes crossed in order to continue doing something like reading a paragraph. without tiring and feeling any visual fatigue and ocular discomfort. So some common symptoms with convergence insufficiency are tired eyes, blurred vision, could be intermittent blurry vision, headaches, because there's a lot of, you're using a lot of muscles and a lot of work goes into looking at something up close. Words overlapping, sleepiness when reading because you're so exhausted from crossing your eyes, difficulty concentrating, or difficulty reading. So it could look, double vision could look very different to different people, looking like a halo around something versus two distinct letters next to each other are actually both symptoms of double vision. It just depends on how far you are down, the double vision road. It could also be horizontal versus vertical. It could be a little bit of both, where it's up and to the right or left. And it could be just straight across, where you're seeing what we know as double. What most commonly people think of when they think of double is two letters horizontally split. The second one is accommodative insufficiency and infacility. Accommodation is our ability to keep our eyes in focus and that flexibility of switching distances, such as copying from the board or looking somewhere far away and then back. So our pupils are like camera lenses. When we look far away, they expand in order for us to keep things clear. And then when we're looking up close, they constrict like a macro shot. So that change, that plasticity going back and forth is sometimes lost in TBI. And so things might look okay far away, but then if you make the quick movement to look up close, it might be blurry and vice versa. Sometimes you might be able to do it, but not have the stamina to keep doing it back and forth without that blur or fatigue. So common symptoms would be blur at different distances, headaches and discomfort, fatigue, sometimes double vision, because there's a fine line between blurriness and double vision. Nausea or motion sickness when you switch distances. And I hear that one a lot with traumatic brain injury survivors. Putting my glasses on, taking them off actually makes me motion sick. And loss of concentration during a task because of all of these other symptoms.
Oh, and Dr. Almouradi, so you said we could stop and ask questions anytime?
Yes, absolutely.
Great. So something that I think, Lauren, that you were bringing up that was really great was that I have questions about too, was ocular migraines.
Yes.
And so maybe could we speak on how ocular migraines could kind of fit these symptoms?
Sure. So a lot of the headaches that are related to vision are closely linked, kind of like ocular migraines. So if it hurts right around the eyes, the forehead, and if it's brought on with triggers that have to do with near work or maybe light sensitivity, then that is something, if you've never had it before or you haven't had migraines before TBI, then it is something that is directly linked to vision and traumatic brain injury and how those eye-brain pathways are weakened by TBI. So, and the severity varies as well. So that's why this is so customized, because it's different from patient to patient. Even if you check off the same symptoms on a symptom list, you're not exactly going to have the same symptoms and the same severity as someone else.
And Eric, Dr. Link?
Yeah. Dr. Almouradi, have you had any experience with a TBI causing cataract?
Yes, that's a little bit different. So when it causes a cataract, it would require surgically removing that cataract, so it's not in the way and causing blurry vision or faded vision. With vision therapy, it's a little bit different in that we're getting to behind the cornea and the lens and where the cataracts are into the brain and rewiring the brain in order to see correctly again. So a little bit different, but yes, that is common. That does occur.
Okay. Thank you.
Absolutely. Any other questions so far?
I have a question.
Go ahead.
Can can an ocular migraine mimic the symptoms of a TIA?
It could. With TIA, it lasts less. It's up to 24 hours, but most likely about 3 hours. And so it could. We would have to do some differential diagnosis in order to pinpoint which is it.
And TIA is transient ischemic attack, so like a mini stroke, right? So
Yes,
that could
exactly.
mimic with the ocular migraines. Awesome. And Lauren, you had a question there?
So, doctor, I had a question.
Sure. Go ahead.
I'm wondering if the stroke in the brain also occluded partially or fully the blood flow to the eye, which has affected the retina itself. Is there any help out there to regain that retina, or is it just whatever damage has been done is irreversible?
So it would depend on the damage itself. If it was an ischemic stroke, it would depend on how long ago that was, and I would have to look at those fundus photos that was taken by the optometrist or ophthalmologist to see if it scarred over or not. Sometimes with visual field loss, if you have like the right side you can't see out of anymore because of an ischemic stroke, sometimes we can work on compensatory vision, so you can open up a little bit more of that side vision that was lost. But if there was permanent damage, then it could be something more like occupational therapy, where you're now doing different things with head turns and stuff like that to sometimes even prism, in order to move the image to where that big blind spot became, so you can improve your activities of daily living.
I see.
I have a question. If you wear progressive lenses, how would that affect your sight? Because like I do, and it's like I get blurry all the time, but I don't know whether it's I just not looking through the right part of my glasses or whether it's really blurry.
Yes, that part is tricky. So it would depend what traumatic brain injury you've had and whether or not you've had hemanopsia, so a loss of a visual field. If it's just blur without loss of visual field, the first thing we would be having to do is to see whether or not it is just the adjustment of the glasses. So sometimes with different kinds of progressives, the corridor that's in the middle vision, so for that intermediate distance, might be too small, and we would have to open that up. That usually helps. But if it is blur not having to do with progressives, then there could be something there that could be fixed. So, but the first step would be to play around with the glasses themselves, have the optometrist look and check your vision and all of the distances that the progressives are supposed to be there to clear, and then rule that out before moving further.
Thank you.
Lauren, you had a question there, Lauren?
Yeah, so those slides are super helpful with the double vision. That was almost identical to what I've been struggling with. But I did have a question of when I'm in a different, like if I'm laying down and watching TV, that usually like before the accident, I could differentiate, like, I don't know, my brain would automatically, I would know what's up and down and left and right. For example, and then when I turn, it's like the entire TV turns like with me, or I up is not up and down is not down. And so I was wondering if that's related to like double vision, or more of like the eyes meeting at the right point, because it all kind of like blurs, and at the same time it's like the entire like wall shifts with me. I don't know if that makes sense.
Yes. So if it blurs and you have your most current prescription on when it blurs, then yes, that would have to do with eye focusing issues, where the directionality part, where if you would turn, it moves with you, that's more information processing. And so we'll get to that a little bit later in the PowerPoint. It's how your eyes are processing the information and how they're taking it in, and then you knowing what you saw. And so sometimes there is a little bit of a delay and decreased reaction time to what was seen. And so you might notice things happening where it's tilted, where you know it shouldn't be tilted, you just tilted your head. That is common. So I totally get what you're saying. The double vision, that we would have to know exactly why it's happening, based on history and what kind of accident. Medications sometimes have side effects of that. And so it really depends. But if you are wearing your latest prescription and everything that you should be doing, you are doing, you're still having double vision and that tilt, then there could be, it could be worth to at least get the evaluation done where you can rule out things and pinpoint diagnoses and then go from there.
Thank you.
Absolutely.
Next slide.
Yes, please.
Hey,
Yes.
All right, so with accommodation, the eye focusing issues, this is just an example of how blur looks like when you're looking at a paragraph. The range can definitely vary. It can be slightly blurry, where if you just move it real close, you can do it. Sometimes it's too blurry and it's very frustrating to do, to even carry on with your life because of it. And so I put this slide in mostly for caregivers because it's hard to know exactly how the TBI survivor is seeing. And so it's always good to have visuals. All right, and then the third one here is Cycadic Dysfunction. So saccades are very small eye movements we make when we move from letter to letter or word to word as we read, or if we're tracking something down. And so ideally, you're supposed to have, you look at one word and then centrally, you're looking directly at it when we're reading. And then your side vision kind of tracks down what's happening next. It happens less than a second. It's very quick, but it's just part of the processing where with your side vision, you're anchoring yourself with the next word, and then you make one smooth eye movement between one word to the next. With saccadic dysfunction, both eyes are not working as a team. And so one eye might go to the next word and the other eye could trail it, or it can jump to 2 words down and then come back to it, where we're skipping words and having to slow down our reading in order to find the correct word. Common symptoms with saccadic dysfunction are, like I just said, slow reading, having to use your finger as a marker or a little reading window in order to find your place, headaches because the eyes are not working together, a lot of ocular discomfort, so pulling around the eyes or between the eyebrows, loss of place when reading, poor sports performance because you have to track a ball down, you have to look at everything on the field in order to process it. Clumsiness, lack of coordination, especially hand-eye coordination, difficulty with numbers and math and having to line everything up, and a slow reaction time to something you see. And so that slow reaction time is usually seen in difficulty driving, having to switch lanes, making a fast decision as we drive. And so these are just visuals of how eye tracking would look like and how the eyes should be moving versus when they are not moving in sync. All right, and so we're going to be talking now more about the information processing and the difference in traumatic brain injury, closed head injury versus concussion, and then with acquired brain injury, the stroke and different cranial nerve palsies. All right, so with acquired brain injury, that's the big umbrella, and then under it would be if it's external versus internal. And so we have traumatic brain injury if it was something that happened external to the person. And then internal would be something like a stroke, a cerebral vascular accident, arteriovenous malfunctions, and any surgery complications that would lead to an acquired brain injury. And so closed versus concussion. So you probably already know this. There's a lot of different causes of traumatic brain injury. One of the most prominent is a fall. So whether it's just falling, or a motorcycle accident or high contact, something that hit the head, causing a traumatic brain injury.
Yeah, and mine was a fall. Are there other TBIs around? Who was someone with a TBI or a motor vehicle accident?
Mm-hmm.
Or in motor vehicle accident there? Or
yep.
Michelle's also, right.
And so what happens in TBI is that there is what's called a coup and a counter coup. So the coup is where the head gets hit. But as we know, the brain itself is not static, and it is sitting in a liquid. And so if there is hit on one side, it's going to ricochet into the opposite side. And when it happens to either the front or the sides, but the counter coup ends up being in the back of the head, that's where the visual cortex is. And so that's where a lot of the visual issues occur due to the damage to the back of the head. So like we talked about, motorcycle or vehicle accident and any trauma with high contact sports or any hit on the head. The most common ocular symptoms that we do see with traumatic brain injury survivors is visual efficiency dysfunction. So 90% of traumatic brain injury survivors have that, where the eyes are just not working together. 82% have a feeling of being overwhelmed in a busy setting. So going to the grocery store and just walking down an aisle, having to pick up a can of corn when there's a bunch of different cans around. Maybe some of them are all corn, but you just can't filter out the one you want. Everything is coming at you in the same importance. Your brain can no longer filter out what is needed. And so it's just, it's overstimulated with visual impact. And so that happens a lot. Just being in a noisy setting sometimes triggers it as well. Being, having to talk to someone, but having someone else have a conversation right next to you is very overwhelming. And then double vision, eye strain, and headaches with near work are also very prominent ocular symptoms. And so with concussion, like it was mentioned earlier with the movie concussion, football, any boxing, any kind of high contact sport, really increases the percentage of having a hit to the head. And then falling or any injury that shakes the brain. And like I said, it doesn't have to be hit in the back. That counter coup just needs to touch the back, and that would be enough to cause a visual issue. With a concussion, eye focusing, eye teaming, eye tracking deficits are very, very common. And concentration difficulty and light sensitivity are also very common with concussion. So neurological visual rehab treats the ocular symptoms. We always have to start with a normal eye exam. So you want to make sure that you have that taken care of first, because we want to make sure that you're in your best corrected contacts or glasses, that everything else structurally is good about the eyes and the back of the eye, the retina. And so, and then if there is any prism needed in the glasses, we would have to do all of that stuff first before moving on to the visual efficiency and visual information processing evaluation. And so vision therapy treats any underlying eye teaming and visual information processing issues. And we're just rewiring the brain to correct these processing of visual stimulus that's lost to brain injury or disease. And so there is a symptom checklist, which is a really good way to know whether or not this might be something that's right for you. And I think Daniel has a copy of it. So you basically just go down and think about the last couple days and how you've been just doing your activities of daily living and whether or not you're experiencing any of these symptoms. And there are things we talked about like double vision, headaches, feeling nauseous or motion sick, miscalculating your step up and down the stairs, any depth perception issues, things like that. And so this is really good feedback for you to, before you even commit to anything, just know, do I have visual symptoms, visual issues because of my TBI or ABI?
And I'm just gonna stop this real quick so I can share the checklist with everybody in the, everybody here. So check in the chat. So I just shared the brain injury symptom checklist from Dr. Almouradi, as well as the Convergent Insufficiency symptom checklist. So that way you can see and sort of differentially see what might some of the difficulties you'd be having. And so, yeah, that's in the chat. And I will share the screen again. All right.
All right, so that was traumatic brain injury, and we're now going to be talking about internal ABI, such as a stroke, any different cranial nerve palsies, midline shift syndrome, and post-trauma vision syndrome.
Oh yeah, and so I guess right here, anyone who's dealing with stroke, like either a rupture, a brain bleed, or a blood clot, ischemia. Oh yeah, we have a couple people. Great, yeah.
Okay, so it is very, very common. It's actually the most common thing that a lot of traumatic brain injury people that I see most commonly have had a stroke. And so the most common symptoms that occur because of a stroke is visual efficiency dysfunction, so problems with using both eyes together, visual field loss. And visual field loss can look like, you used to be very on top of everything, you know where everything is. You haven't moved before, before versus after your stroke, you're still in the same house, but all of a sudden you're bumping into furniture that has always been there in the same place, or you're not seeing one part of the room when you come in. And so that is usually very common. It also translates into poor handwriting, hand-eye coordination, pouring a glass of milk, you're miscalculating where that glass is and you're sometimes pouring it outside of it, things like that. And then with ocular motor dysfunction, so reading difficulties, whether it's double vision, blurry vision, or just feeling like it's a lot of pressure between your eyes, or every time you read, your head hurts. Just low stamina in looking at something up close. And then visual vestibular dysfunction. So that's what we had talked about with feeling overwhelmed in a busy setting. And then in some cases, accommodative dysfunction. So the inability to keep things in focus up close or when shifting between different distances. And so during recovery, there are multiple residual effects, deficits that happen, even if the stroke itself, you're seeing your primary care doctor and everything looks stable, there might still be some things that are overlooked, such as vision. And neurological visual rehabilitation should begin as soon as the patient is stable. And so, if some of the speech came back, if they're everything, the medication dosage is now at a stable rate where the doctor doesn't keep changing them, then that's probably a good time to get the visual evaluation done. And that changes, that differs between patients. With cranial nerve palsies, this usually is caused by ischemia. So if it is a stroke, then it would be the one where the blood does not reach the area. So like with a blood clot, for example. Also occurs with diabetes, high blood pressure, and Bell's palsy. And so this is just a visual to show the different, which cranial nerve causes what. And so with a third nerve palsy, the eye would be down and out. With the fourth nerve palsy, if you would see right there, it would be one eye would be looking up, in and up, or just up, just depending on where it happened. And then with a sixth nerve palsy, the eye would be turned in. And so that could be temporary, just depending on the case, or it could be something that lasts well past someone is stable physically with everything else. And that's when vision therapy could come in. And then, so if you can go back just, sorry, one more thing on the one before it. So if trauma happens to the head, then that's when the fourth nerve palsy would happen. And so a lot of high contact sports and falls, we would see a fourth nerve there. Okay, you can go to the next one. Thank you. And so double vision and peripheral or central blur are very common. Peripheral blur, so sometimes patients have a hard time noting the difference between a visual field loss, where it's something like that can't be recovered, and just a peripheral blur that can be recovered. And that is something that we would have to do during the evaluation. We would be able to differentiate the two. And then metamorphopsia, which just means a change in shapes. And so if you're walking down the hallway, you feel like the walls are caving in or out, and that was not there before. Or walking in a straight line, you think you're walking in a straight line, but you are actually bumping into things or the wall as you're walking. And so that's when, you know, these symptoms directly have to do with your vision and how the information is being processed. And so a visual efficiency evaluation would be a good, you know, if you're having these things, that would be one of your primary kind of gateway to see what's going on, or at least rule it out. Midline shift syndrome. So this one, not as common, but you know, it also warrants a slide, I thought. So this is has to do with visual neglect, and so it's a perceptual deficit where the patient doesn't attend to one side of his body. So they only groom one side of the face, or they eat half, you know, straight down the middle, just half of the food, and they don't actually notice or see the other half on the plate. And so signs of this are similar. They kind of overlap, where it's bumping into objects, but it also is different in a way where neglecting grooming one side of your body, or like doing nails on only one hand and not the other, that's very specific to a midline shift syndrome. And post-trauma vision syndrome. So this is as a result of traumatic brain injury or ischemia to the brain. And it disrupts the vision process that's responsible for the peripheral fusion. And so an unstable visual processing system almost always has an unstable periphery. And so with vision therapy, we're able to open up that side vision, and increase the awareness of not just central, but also side vision at the same time. That really helps the information processing and the reaction time of what we're seeing to occur at a normal rate. And so signs with this, just like a lot of the information processing is being overwhelmed or just uncomfortable in a crowded environment or a busy setting, or a lot of visual stimulus, a place that has a lot of different colors and choices.
So I'm ready. Yeah, so for here, the post-trauma vision syndrome, being overwhelmed in crowded environments, is that also related to the visual vestibular concerns?
Yes, absolutely. And so the visual part is taking in all the inputs, but then that the vestibular portion is also there at the same time. It just exasperates it when there's a vision issue in it as well.
Oh, okay, great. And also, if anyone has any questions, please.
Yes, absolutely, anytime. And I can't see, so if there's like the raising hands and stuff like that, sometimes it's difficult to see with everybody. So just feel free to just speak right away if you have any questions.
Michelle? Yeah.
I have two questions. Thank you very much, or first of all, thank you very much for the presentation. The first question is walking downhill makes me so dizzy. And then my second question was one that Lauren brought up on Saturday, and it's changes in patterns on flooring causes almost like it to become blurry, or to like, Lauren might be able to describe it better than me, but it's like changes right in front of your feet where the flooring changes, or there's different patterns like in a movie theater.
Yes.
Those are my two questions.
So with the different patterns, it's blurry, or it's you're nauseous looking at it?
Both. It would be both, yeah.
Yes, yes. And so the blur, it's kind of, you think about it like if you're looking at some of the optical illusion books and you kind of see it blurry or moving, and that definitely has to do with the visual vestibular syndrome. And so you're trying to take in all the information, but it's very busy. And so it's difficult to filter out that this is a floor and I can just ignore it and keep going. It all comes to you with equal importance. And so, and because it's overwhelming, then you feel kind of like motion sick or nauseous doing that. So yes, that is definitely one of them. And then walking downhill, absolutely. So it's doesn't have to just be stairs. It can just be like a normal, just downhill ramp. It's difficult because what you're seeing and how you're moving are usually instantaneous. Like you see it's downhill, you just walk downhill, but there is a miscalculation in TBI where it takes longer for the brain to tell you that this is downhill, and so you misstep, or you feel like you're kind of too high as you're going down. Yes, that is common. Absolutely.
Thank you. Thank you very much.
Yeah. Violet has a question. Yeah, go on.
Yeah, yes, thank you. Thank you. This is such a great presentation, and thank you so much for being here, Dr. Almouradi. So okay, I have, well, first of all, the signs of being overwhelmed in crowded environments is to the T. And it's something obviously compared to my previous, I call it my previous life, I didn't have an issue with, and now I can't do that, which is another reason why I now prefer to stay home.
Yes.
But one of the challenges I've been having in figuring out is, and I don't know if you can also help to understand. I was trying to type it, but it was too long of a question to type. So my accident was 7 years ago. And now 7 years later, I've recently been developing visual issues. And in the previous slides, I've been seeing like all these things that I'm just thinking to myself, tick, 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 because I've been, in the last year, I've had maybe 4 or 5 different appointments with a neuro ophthalmologist, and optometry repeatedly. Because they were trying to figure out what's going on with my vision, with pain, the blurriness, the shaking. Why is it happening now? Why didn't it happen earlier? And also, I have fibromyalgia. That how I've had that before pre-accident, and it worsened post-trauma. And I developed hyperthyroidism, which my doctors are explaining, came about as a result of the trauma. So I'm a walking mess. And with my vision and the severe pain, now having ocular migraines, why is it happening? And have you discovered that yes, it indeed, because it can happen years later for a patient with TBI?
Yes, so it can happen later. It is more common to happen at the same time, where everything is just weaker and you notice all the symptoms. However, sometimes it does happen. So you said you developed hyperthyroidism, and so there are other weaknesses that are happening, and so maybe you already had enough stamina to compensate for the vision issues that happened post-accident, but at some point the visual system gives out, and that stamina can no longer help. And it's because, now you're saying you're getting the migraines, and so with the visual ocular headaches or ocular migraines, that is a sign that you had stamina and you just pushed through it, and it's no longer there. It's just now the visual system is fatigued. And so that does happen. I'm currently seeing actually a couple patients that are 8 and 9 years post-traumatic brain injury. And after about 5 years of the brain injury, they started noticing some visual issues, but then they just pushed through it. But there came a point where they could no longer do that, and it was just everything kind of broke down visually, and so they started having the symptoms, and they couldn't get rid of it with any compensatory things that they were doing before. And so yes, that is common. It could happen, and that sometimes that is good for the prognosis, and of course that depends on the evaluation, but if you had enough stamina and now your visual system is fatigued, it's usually quicker to get it back if you're doing vision therapy than if you didn't really have the stamina to begin with and we have to build it. And so sometimes the prognosis is better when that happens, when you're able to hold on for too long, and then
So vision therapy would be the solution.
So the evaluation itself will show if you're a good candidate for it, and if there is nothing else going on that would prevent the prognosis. And so that's really always the first step, to make sure you're a good candidate for it. If you are, and if it shows that these things have a good prognosis for you specifically, then yes, we would move on to the therapy sessions themselves. And it's a process, and it's just like occupational therapy, physical therapy. You just, baby steps to build on different skills, and then move on to more high level skills as your eyes get stronger.
Thank you.
Absolutely.
Angelica, you had something?
Yeah, I'm wondering if you have come across stroke patients who start to have hallucinations.
So with hallucinations, yes, that is something that could happen, but it's not something that vision therapy can help with.
Mm-hmm. I see.
Yeah, but it is a side effect.
Mm.
For Deborah?
Yeah.
Hi, I have a question. Is it possible to not see things that I have if I have a glass and I don't see it, but I know it, and I know that I can see it, but I can't see it, and then I'll an opportunity to go walk over and I see it is there. Is that making any sense?
So it's there, but are you looking directly at it where you can't see it, or is it more in the periphery?
No, it's right there. I like, oh, I forgot that I forgot my phone was there, and I know that I can't find it, and I'll go back, and then it's there.
Oh, I see. Okay. So you see it, but then sometimes you kind of, there's a visual neglect where you don't see it and then it comes back.
Absolutely.
Yes. So that is information processing. Sometimes if you were to look at something and then the visual stimulus told you now that your phone is there, then something else happens where it takes precedence because you're having a hard time holding on to that visual information until you maybe look away and come back and say, oh yeah, it's right here now.
Oh, okay.
Yeah.
Just make sure.
Yes.
Yeah, thank you.
Absolutely.
Lauren, there was something you had there, or Lauren?
Oh, it was just like Angelica said about the hallucinations. It was just I wonder if this is related to the information processing with in terms of when I'm reading. And I notice that I do get pretty tired. I see a lot of like, it's almost like my eye is quivering, but on top of that, the double vision, but also sometimes the word, sorry, my dog is sneezing. Sometimes the words will kind of like float around the page. And so they're still words, but it almost feels like I'm in a Salvador Dali painting. Like everything just kind of starts melting.
That's not that part. If you're looking at something and the lines are like in a paragraph, their words are swimming on the page or jumping on the page, that's actually your eyes not teaming together. You're not hallucinating it. That's one of the most common things with eye tracking issues, is that one line would just jump up to the next one, or certain words would float on the page. So you prescribed it exactly as it's written on the checklist, actually. Yes, that is something that can happen. And it's because you have one eye that's fixating, the other eye is not really fixating, and it's not being able to work as a team with the other eye. And so you're getting those discrepancies of things not being anchored in place. Yes.
Oh, thank you.
Eye tracking issue.
What causes the eyes to hallucinate?
And so that part is when the eyes are just not working together. So not crossing at a specific point. Sometimes they cross, but not enough. And so you start seeing double. Sometimes they're shaking because there's not enough stamina. So you see things on the page moving around or shaking. So, so if that's what's happening, then it's not a hallucination. It's just themselves not looking correctly.
No, but I'm like seeing people and places which I know at the same time that I'm seeing it, I know that they are not real, but I see them.
Oh, okay. Yes, that's different. So that has nothing to do with the eye-brain relay center itself. There are a couple different things, like Bonnet syndrome, and it's if they're not scary, they're just they're there, but you're not you know that they're not there.
I know that they're not there, but I'm seeing them.
Yes, so that is something that could happen due to traumatic brain injury. It's not really the vision itself, it's more of just neurologically is you're just seeing these images occur. So it's unfortunately not something that can be fixed with vision therapy, but it is, textbooks do talk about that as a side effect of traumatic brain injury.
And here's the overall.
Okay, and so the process itself on how to get, what do I do now? Now I know all this information, what happens? And so if you are having visual issues, the first thing you need to do is see an eye doctor, just to check your annual exam, just to make sure that everything from front to back of the eyeball itself is healthy and within normal and nothing is going on. If you need glasses, updated, prescription or anything like that, that all needs to be taken care of first. Then the visual, depending on what symptoms you're having, it can be, you could need a visual efficiency evaluation, or a visual information processing evaluation, or both. It just depends what the symptoms are. So once we pinpoint the different diagnoses based on both subjective, you saying what your symptoms are, and objective, my clinical data in the evaluation, then we can go from there to see if you're a good candidate for vision therapy and if it will help and what the prognosis would be specific to you. So once that happens, the vision therapy itself, it's just once a week for 30 minutes, same day, same time usually. And you just come in and we work on your we're tackling different things at the same time because that's how the brain works. We just kind of simultaneously make the eyes and eye-brain center stronger, and we build on the exercises, and they get, the increase in difficulty until you reach your goals. And so there are prescribed home exercises, and so you have to, that repetition is key during the week in order to learn a new skill and rewire the brain. Every 10th session, there's usually a progress check and evaluation where your results are compared to baseline, to your own improvement and progress, and to age norms. And then another report is written at that time in order to see where we're at and how the progress has happened. Once everything is done and all the, you're done with all your sessions and you've reached your goals, then we have some maintenance home activities that follow in order to wean you off of the home exercises, because we can't just stop in order to prevent regression. So once, that happens for about a couple months where you're just doing home exercises at a less frequency. And then I'm only seeing you one time after your graduation, 1 month out and 3 months out. Usually if everything looks good on those two follow-up evaluations, then the regression, there's probably not going to be any regression in the newly learned visual skills. And so it's not lifelong learning, it's just something where we can reteach the brain the deficits that occurred because of traumatic brain injury. And it's like learning how to walk. Once you are taught that, then that's it. It's just your eyes and your brain know what to do to look accurately every single time. With the visual efficiency evaluation, we are looking at depth perception, color vision, eye teaming, eye tracking, eye focusing, and the accuracy of your visual system, and just how this is affecting your activities of daily living. And so one of the biggest things is that if you don't need glasses, or if you are wearing glasses and you see 20/20, that has nothing to do with whether or not you're seeing double. That has nothing to do with intermittent blur. So your prescription has nothing to do with what we're talking about with the back of the eye, the eye-brain relay center. And then with information processing, that evaluation, we are taking a look at a battery of tests. We're looking at your directionality, laterality, your fine hand-eye motor skills, your memory, sequential memory, visual discrimination. Are you able to filter something out of a busy setting and look for it and find it, even though there's a lot of visual stimulus around it? And visual attention. And so this is part of an entire interdisciplinary rehab team, the Neuro Optometry. So you may be familiar with things like occupational therapy, physical therapy, just primary care, and internal medicine. Just, we all work as a team in order to get a holistic approach to each patient. And so when I write my reports, I always encourage the patients to send it to all the other professionals that they're working with, in order for everybody to be on the same page and for everyone to have similar charts. So you're not, coming into primary care and they're only looking at the structure of everything. There's also neurology involved, especially in traumatic brain injury. All right. Any questions? anything you want to talk about?
Great presentation. Thank you so much, everybody.
Thank you.
Thank you.
I have to agree, fatigue is part of rehab.
Yes,
Yeah.
absolutely. And if you come up with any questions as you're thinking about today, feel free to email me anytime. If you have things, questions about your specific visual needs and your specific symptoms that you've been noticing, also, just email me anytime. And
thank you.
Hopefully, good luck with everything. And hopefully this is something that you can, check it off your list. One less thing to worry about with all the symptoms.
Yeah. And actually, for another thing, for Dr. Almouradi, if you can, for survivors or any of us who would like to access you, you're located in Brea, and
Yes.
you can also do virtual sessions.
Yes, I have been. So since COVID began, I've been doing virtual sessions as well. And so that usually on Saturdays, but it really case by case, we can figure that out. Yeah, definitely. So you can email me about that as well.
Is it covered by insurance, doctor?
Daniel, about connecting with you, or
what was that, Violet?
Should we email you about connecting with Dr. Almouradi, or?
Her email is on right here. So Dr. Almouradi Vision at gmail.com.
I'm so sorry.
Mm-hmm.
No, and also it's in the email. If you just so happen to misplace it again, it's in my email. Dr. Almouradi's email is attached, and all of this and the slides are attached as well.
Yes, there is also a Facebook page. It's if you just look up Vision Therapy Dr. Almouradi, it should you should see it. So I put a lot of patient education information on there. So that is also something that could be beneficial. A lot of traumatic brain injury patients connect with each other on there as well and share different stories. So that is it's a very good community tool for everybody.
It is, yeah. And Amy, you had a question there?
Yes, doctor. Is it covered by insurance?
So unfortunately, it's not covered by most insurance. We can take a look at your specific insurance and see. It's usually not. It's just politics with ophthalmology and optometry and everything. So, but I do have a sliding scale. So it really kind of, patient by patient, we try to work with everybody as much as we can because I know it's once someone has traumatic brain injury, hours are reduced and with work and everything, it's difficult. And so, yeah, we do have a sliding scale.
Thank you.
That at least helps. Thank you.
Yeah, absolutely.
Yeah, I put your Facebook page, Dr. Almouradi, in the chat. So go and see there. She's got a lot of great content materials up there. And Lauren, you had something?
Yeah, sorry for so many questions. This is just so awesome because I can't tell you how many times all these symptoms that you're talking about and that there's a reason behind it. I was put into that they would just call it psych and said that they had to go see a psychologist. So I just wanted to thank you again. I love how Violet describes this too, because I've been seeing it a lot. It's not necessarily like painful, or it's just more of a nuisance. She calls them paparazzi flashes, but it feels like almost like a cartoon when you see the stars like around after they hit the head. And so I was just wondering if that was the ocular migraines or the because it happens.
Is it like a trigger right before, like an aura right before the migraine, or do you sometimes have it when you don't have a migraine?
Both. So sometimes like I can tell when my cognitive symptoms are increasing, like it'll happen more often if I'm really tired, or and other times it'll happen completely outside of like, oh, I thought I was fine, I guess I'm not. And I've gone to the heart doctor, I've gone to the eye doctor, I've gone to like all these doctors to check it out. Nope, you're fine. And so I was wondering if that's a brain.
Yeah, so the first thing we think of when you see flashes of lights in a normal situation would be something with the retina, and it usually happens to older patients where the vitreous is pulling at the retina, and that's what you're seeing as flashes. But in your case, it's not. This is more neurology. And so sometimes when things are shook up in the brain, we have neurons that just fire. And so when they're firing randomly, you actually see that. And so that's why when you're tired, your entire body's fatigued. And so that's gonna happen. You're gonna feel it. Sometimes, and it's unpredictable. So sometimes it goes away with years, past the injury. And sometimes it just decreases in frequency. But it is, it is something where neurologists commonly find that. And it's just the neurons firing in your brain and then you seeing that.
That's actually kind of cool. Thank you.
Seeing with your brain and not your eyes.
Neurons firing. Interesting.
Yeah.
Okay, that explains it more. My neurologist couldn't even figure it out. I was just told that they were ocular migraines.
So the migraine is the pain itself, but if you're seeing flashing, and sometimes it could just be because you have a migraine with an aura, and so that happens right before to tell you a migraine is happening. But if it's without a migraine, then yes, that is also common where you just see them, and they're a nuisance. They're not something that you should be concerned about. It's just occurring. It's part of the brain trying to recover.
Oh. Yeah, it's just like Lauren described it. It's not painful. It's just my paparazzi lights.
Yes. Yeah.
It's like, stop taking pictures of me.
Yeah.
Small. Well, so great. Thank you very, very much for your time, Dr. Almouradi. Just all in the chats. Thank you so much for your expertise and your knowledge.
Thank you guys.
Other questions?
Thank you.
All right. Well, then please join me. Thank you very much for your time. Brain injury. Thank you, Dr. Almouradi.
Thank you.
Yeah.
Thank you guys.